Good afternoon, and thank you for coming to listen to me and to share in my observations and reflections on the specialised healthcare sector, the industry which I and my organisation, Care Management Services, serve, and which, as you can see, serves me as one of its clients. Let me tell you a little about myself. To today's conference organisers, I'm speaker number 145. To my consultant, I'm a patient. To my social worker, I'm a case. To my staff, I'm the boss. To my mum, I'm her darling son. But the most, I'm just a bloke in a wheelchair. Actually, I suffer from Duchenne muscular dystrophy. That means I have very severe limitations on my physical ability and mobility, to the extent that I require the support of a range of sophisticated equipment and a team of personal carers to manage day to day. For 15 years, my team has been creating bespoke packages of care for young people with complex care needs based on the challenging blend of their extreme physical need and high social and professional aspirations. Thanks to the investment over the post-war years in medical research and advanced treatments and the availability of resources for primary and secondary health care, more such individuals are surviving genetic disease and emerging into society and developing expectations. This has exposed the limitations of our institutions and procedures of our poor understanding of inclusion and integration, and the pressures on meeting those challenges of stretched public funds. This talk identifies the obstacles to reconciling these conflicts and offers models of collaborative practice that have delivered amazing results for some of society's most disadvantaged people. The issues of managing transition from childhood to adulthood in people with chronic genetic and life-limiting disorders are increasingly important, because as a result of advances in the understanding, treatment and management of these conditions, people are living longer, fuller and better quality lives. Not surprisingly, they are developing the same aspirations and expectations that any other young person might do. These aspirations might include full access to education. This might be mainstream or even higher education. Real employment opportunities, not just occupational or voluntary activities. Independence from parents, even independent living. Travel at home and abroad. Mature and long-lasting relationships outside the family. Varied, stimulating, even exciting social opportunities. And involvement in or control over management of their own care arrangements. So what can be done? I was diagnosed with Duchenne muscular dystrophy at the age of 3. Throughout this progressive muscle wasting disorder, I have focused on leading a normal, active family life. This has taken me through 14 years of mainstream education, and at the age of 18, I left home to undertake a 4-year business degree at the University of Northumbria, from where I graduated in 2001. During this time, I lived in a specially adapted flat on campus, which I spent a long time planning and equipping, along with experts from a variety of statutory and voluntary agencies. The process of coordinating and resourcing this specialist facility was complex. I created and trained a team of 5 carers drawn from the student population to provide round-the-clock care to enable me to participate fully in the university academic and social experience. This included working for a year as a management trainee with Marks and Spencer's. After graduation, I was able to take my own care team with me to my new independent home in Newcastle upon Tyne. In 2002, I established a business, Care Management Services, CMS, to provide advice, advocacy, support, and actual care services to other young disabled people who wish to live independently. Over that period, CMS has supported 20 young people in living independent lives, as far apart as Norfolk to Lancashire and Portsmouth to Aberdeen. We deal principally with severe neuromuscular conditions, sometimes with attendant health issues requiring physiotherapy, management of stomas, epilepsy, and sophisticated respiratory support. Like my clients, I aspire to a rich and fulfilling life and have a desire to help and serve others. I am a member of Rotary International, having previously been president of my Rotaract Club. I go carriage driving at weekends, regularly visit the theatre, musical concerts, and local and national sporting events, and also attend conferences like this to address other such distinguished audiences. I and my clients have travelled to most West European countries, including to Norway, for an international outward bound style handicap, and CMS has sponsored through Rotary 5 other disabled young people, complete with care teams to subsequent camps. Gratifyingly, these achievements have attracted some recognition and reward recently. So what drives these changes? I described earlier the changes that have taken place in our society with regard to the need in social care and aspirations of those cared for, and the corresponding failure of our agencies to respond to these changes. Research, greater education, more young people at university, and the development of therapies, treatments and management techniques have all contributed. While government of whatever colour tries to reflect these changes, the resources available to enact these changes often lag far behind. It is without doubt that the expansion and centralisation of state control has made those in need more dependent upon a series of authorities, agencies, and quicos for the provision and support for aspects of our lives that are really quite basic fundamentals to our everyday living. Care support for our basic living needs, support for getting around, adaptations to our homes or our schools and colleges, access to our places of work, special tax arrangements so that we can retain more of our income to meet the additional costs of living with a disability and a degenerative disorder. These are areas of our lives that others, able-bodied people, don't require help with. They are able to exercise choice and control over all these simple, fundamental, everyday issues. However, we are reliant upon Acts of Parliament, white papers, regulatory authorities, assessments, needs testing, local government policies and officials, the health service assessors and commissioners, 32-page application forms, multidisciplinary team meetings, in which we are often not even invited to participate. This process is designed to provide the means to independence. It sounds more like dependence upon the will and the whim of others. In so many cases, good intent from central government in the form of initiatives and funding is devolved to local authorities to address real needs, like additional funding to meet the known needs of those with higher level care needs. But here's the rub, it's not ring-fenced. The local authority is not bound to spend the money in the way in which it was intended. Instead, it is often siphoned off to address other priorities within council offices, often resulting in the protection of council jobs at the expense of meeting the other needs of the community. So what is so difficult and why? In the transition from childhood to adulthood, one might need to interface with some or all of these agencies. There has been recognition within statutory services for some years that preparations for access to adult services for young people with chronic disorders must begin early. This reflects the normally divided structure of provision between pediatric and adult services, and has often been addressed by the appointment of a transition caseworker or team. Unfortunately, that has not translated into a smooth transition to the provision of services because of certain generic factors. Statutory services are not quick to recognise the dynamic nature of degenerative disorders, with assessments and provision often lagging many months behind changes in needs, leading to late delivery of services and facilities that by then are inappropriate to meet changing needs. Greater longevity in life-limiting conditions is leading to increased aspirations, which are both extremely complex and extremely expensive to service. The hierarchical structure in many statutory authorities, health and social services, etc., adds delay and complexity to decision-making and authorization of expensive and complex solutions. Since the Direct Payments Act of 1996, local authorities have been demonstrably reluctant to release control of care provision to the service user for a variety of reasons: power, unions, loss of budgetary control, lack of trust in the client, etc. Client or service user needs are so complex and broad-ranging that few, if any, caseworkers or managers are able to effectively coordinate all aspects of service provision. True collaboration between services and authorities is still remarkably rare. Reluctance to accept the expertise or authority of the client or family in key matters. Central government resources which start as generous or adequate being absorbed by the administrative and assessment process so that little actually filters through to the service user. Look at what has been said about direct payments by In Control, the government-sponsored independent charity for the reform of the social care system. However, the implementation of direct payments has been typified by a number of problems. Local rules can be unnecessarily restrictive, not encouraging people to be more creative or to negotiate more freely. Management costs are typically stripped out of direct payment. Instead, authorities typically commission such services themselves, further limiting the options available to the disabled person. People who may lack physical or mental capacity to manage a direct payment are not always offered alternative systems that bring similar benefits. The standardized assessment and care planning process that precedes direct payments can distort planning and limit creativity. My clients have proved that even with the odds stacked against them, remarkable things can still be achieved. So what can be done to speed up the process of provision, make it less grueling, and encouraging increasing numbers of young people with chronic disabling conditions reaching adulthood to realize their dreams of a satisfying and fulfilling life? The big society, what does it mean? David Cameron's concept of the big society envisages authority and responsibility for making decisions about how independent living is structured, managed and delivered, being pushed down to the level of the individual. Whilst funding for care provision will continue to be tight for some time, there will be opportunities for those with high-level need to control and shape their own destiny as never before. Big society means small government. It is increasingly recognised in social inquiries and service user surveys that the present system of assessment and provision is not working. The days of people waiting for months or years on the provision of a decent powered wheelchair, electric bed, or regular physiotherapy are coming to an end. I support clients all over the country to access this equipment and these services in new, self-directed and cost-effective ways, bypassing the overbearing and overweight public services. We await the outcome of the recent stripping down of PCTs and the devolution of the commissioning of huge swathes of services to GP-led clinical commissioning groups. I look forward to local user groups and voluntary sector support groups and private sector providers playing an enhanced role in both commissioning and provision. So, what should be done? We must accept that the improvements to the management of late-stage chronic and life-limiting conditions are likely to continue, as are the resources available to fund therapeutic interventions. This will produce a marked rise to the numbers of children with life-limiting conditions growing into adulthood, with a concurrent rise in their expectations and the demand for support to realize these. This in turn will bring unprecedented pressure to bear on resources allocated to young people's services. On the other hand, it can and has been argued that with the UK experiencing unprecedented levels of public and personal debt, the expenditure of hundreds of thousands of pounds of public money on one individual with muscular dystrophy to support a few extra years of independent living cannot be justified when so many other deserving cases are going without. There are undoubtedly limited resources. The public purse will be squeezed for many years to come. However, a transformation in the rights and entitlements of those who endure difficulty and disadvantage has taken place. Society's approach to those with such disadvantage has changed immutably. It has made a commitment to those with physical and healthcare needs that cannot be rescinded. However, much can and should be done to improve the efficiency of the delivery of funds and services to users, and also to shift control of those in greater favour of the user. Local authorities and service providers should participate in the trend towards empowering the service user to be involved, to share or take control of shaping and delivery of services. The government-backed E-Control project has pointed the way for local authorities and professionals to devolve control of care budgets and services to users and their families. Following direct payments of social care funding, individualised budgets now enable CCGs to devolve control of continuing healthcare funds to users in a similar way, saving huge amounts of time, money and waste, and making more efficient use of precious resources. To empower ground-level caseworkers to make more greater and faster decisions, to take delay and cost out of the assessment and administrative process, to collaborate with partner agencies on sharing information, assessments and processes to facilitate faster and more efficient applications. Statutory agencies should recognise and access the expertise that resides in the family, who have often been sole providers of support for many years, to add in the voluntary support organisations. The private sector can and should be more involved in the process of shaping and designing and providing specialist services where authority expertise runs out. Service providers can be more flexible and responsible in supporting creative and individual solutions where this can be done cost effectively. Recognition and support for truly independent advocacy to help service users choose or create the package of care that best suits them and evolves with their needs quickly and responsively. Champions for change must come forward and be recognised by service commissioners and gatekeepers to represent and drive these changes at individual, local and national level. Already amazing outcomes are being achieved in a climate of disconnected services, misdirected resources and overweening bureaucracy. CMS supported Client Guide to Independent Living through 2 years of A-level, 3 years to achieve a first-class honours degree in time planning. A great achievement, but that's not the punchline. This is the punchline. The other person was his girlfriend. Jamie Dye has gone on to complete a postgraduate diploma, membership of the Professional Institute and secure work with a top law firm. To the further step in these amazing achievements, he and Amy get married later this summer. Let's imagine what more can be achieved if we can respond to the aspiration and determination of those who need our help and want to take responsibility for their own futures while we watch this short clip.
I could have been a giant and a bonsai tree, but someone bound my roots and held me down. I could have reached for heaven, sent a snowy owl, but they clipped my wings and kept me on the ground. I think I heard them tell me that they loved me, they'd care for me, without them I would die. What's the use of roots if you can't spread them? What's the use of wings if you can't fly? I could have been a singer, sent a minor bird, but they caged me and they told me what to say. I could have run forever, sent a pony, but they bridled me and made me go them way. I think I heard them tell me that they loved me, they'd care for me forever, so it seems. What's the use of voices without freedom? What's the use of living others' dreams? Why do people cage the things they love the most? Is it simply that they fear to be alone? If you give your love its freedom, it may stay a while. If it leaves you, it was never yours to own. Found adventures and the angel fish. Now my world's so small there's nowhere left to go. I could have ruled the kingdoms and the lion. Now the land inside my head is all I know. I think I heard them tell me that they loved me, they'd care for me and tell me it's alright. What's the use of life without adventure? What's the use of strength if you can't fight? Why do people cage the things they love the most? Is it simply that they fear to be alone? If you give your love its freedom, it may stay a while. If it leaves you, it was never yours to own. I know I had them tell me that they loved me, they'd care for me, without them I would die. What's the use of roots if you can't spread them? What's the use of wings if you can't fly?
Thank you very much, Gordon. We're rather short of time, so I don't know that we've got time for any questions today, but thank you very much again, and I think that was a really inspiring presentation. Thank you.
Okay.